Good morning everyone. Today we will discuss about the topic acoustic neuroma. Okay, as you all know, it is also called as vestibular schwannoma. That means it arises from the schwann cell of vestibular nerve. So that's why it is also called as vestibular schwannoma. So let us go into its details. So as you know, this is the ear, external ear pinna continuing into the external auditory canal, and then the tympanic membrane, your ossicles, and as you go inside there is the inner ear or labyrinth, and from this inner ear, from the vestibule side, vestibular nerves will arise, superior vestibular nerve and inferior vestibular nerve, and from the cochlear side, cochlear nerve will arise. All these three nerves will enter into a canalicular part over here. So this canalicular part is called as internal auditory canal. Okay, so this is your internal auditory canal part. Inside this internal auditory canal, all these nerves unite to form a common vestibulocochlear nerve, and that travels through the cerebellopontine angle. Just before entering the brain, there is a free space, that is your cerebellopontine angle, where here your cerebellum will be lying and the brainstem will be lying down beyond. So this is the CP angle, cerebellopontine angle. Normally the tumor arises in the internal auditory canal part, and it grows out into this free space, that is CP angle, cerebellopontine angle. So when you take a cross section here of the internal auditory canal and see, if you see, this will appear like this. Okay, so if you see, this is the anterior end and this is the posterior end. If you see here the internal auditory canal, if you see from this side, this internal auditory canal will appear like this, and anteriorly, as you see, you can see the cochlea which is placed anteriorly. Here also your cochlear nerve will be lying anteriorly, the antero-inferiorly. If you see the cochlea, it is lying a bit inferiorly and anteriorly, and see the superior part, and this is posterior vestibular part. See the vestibular part, it is here, the superior vestibular part and the inferior vestibular part will be lying, and see if you come to antero-inferior part, the cochlea will be lying over here. So all these fibers will be entering into the antero-inferior part of your internal auditory canal. See the cochlea, see the cochlear fibers all joining to form a common cochlear nerve, and this part enters into this antero-inferior part. And as you go posteriorly, so posterior-inferiorly, as you can see here, there is a inferior vestibular nerve. See the inferior vestibular will be occupying the posterior-inferior part of the internal auditory canal, and above it, if you see posteriorly, there is a superior vestibular nerve which arises from the posterior superior part of the vestibule, and that enters the posterior superior part of your internal auditory canal as well. You can see here in this picture very clearly. If you see, this is the internal auditory canal part. See the cochlear nerve entering antero-inferiorly, posterior-inferiorly your inferior vestibular nerve, and posterior superiorly your superior vestibular nerve. So most frequently asked question is vestibular schwannoma or acoustic neuroma most commonly arises from this inferior vestibular nerve. Okay, this is your inferior vestibular nerve. Okay, so this is here lies your inferior vestibular nerve. So from it, and after that the second most common is your superior vestibular. Okay, so remember this most frequently asked MCQ, and remaining the one quadrant, as all these three quadrants covered by the vestibular and cochlear, the other quadrant will be occupied by the facial nerve. See the facial nerve, you can see lying antero-superiorly crossing the internal auditory canal like this. If you can see here, the facial nerve is cut to expose the vestibulocochlear nerve, but if you see here, the facial nerve occupying the antero-superior part of the internal auditory canal. So that is the arrangement you see, and here again there is a bridge like thing that separates the upper nerves from the lower nerves, that is your falciform crest. And remember, falciform crest is a horizontally lying ridge that separates the superior vestibular nerve from inferior vestibular nerve, as well as facial nerve from the cochlear nerve. And also there is a vertically arranged bony bridge that separates the superior vestibular and facial nerve superiorly. Okay, and if you see the acoustic neuroma, it arises intrameatally and slowly it enlarges and it occupies the cerebellopontine angle, and slowly as it enlarges, it compresses the brain tissue also and the surrounding cranial nerves. So the symptoms will be according to the cranial nerves involved, right? And as this is the vestibular nerve, surrounding this is the squamous cell, and as it arises from the squamous cell, it is called as schwannoma. It also arises from the neurolemmal sheath, so it is also called as neurolemoma. And also it arises from the eighth nerve, that is your vestibular part of the eighth nerve. It is also called as eighth nerve tumor. So coming to the clinical features, most commonly seen in the age of 40 to 60 years with equal incidence in males and females. And when the tumor is lying intrameatally, there will be initial symptoms. So when it lies in the intrameatally, as you know, apart from the vestibular nerve, there is also another nerve, that is cochlear nerve, will be there in the intrameatally. So this cochlear nerve gets compressed with the enlarging acoustic neuroma in the intrameatally. So due to the compression of the cochlear nerves, the conduction of the nerve impulses cannot happen properly. So that causes a hearing loss. And that hearing loss, as it is neural in nature, that is sensory neural hearing loss. And it is unilateral typically, because only one side there is the tumor is arising and causing compression over the acoustic nerve. So that will be most commonly unilateral, and it will be progressive. The tumor it enlarges at a rate of 1 mm per year. So throughout a period of 1 year, it increases in size of about 1 mm. So that much slow growth rate will be there, so that mildly the acoustic nerve will get on compressing, and so gradually increasing hearing loss will be presented by the patient. Apart from that, due to compression of these nerves, tinnitus will also be a complaint. So typical presentation of a patient will be, so gradually progressive unilateral sensory neural hearing loss with tinnitus will be the initial presenting symptom. Okay, and if you see the cranial nerve involvement coming next, once the tumor from the internal auditory canal, once the tumor expands into the cerebellopontine angle, it compresses the fifth cranial nerve immediately. So once it reaches approximately of 2.5 centimeters after coming out from the internal auditory canal, once it becomes 2.5 centimeters bigger in size, it starts compressing the fifth cranial nerve passing over here. If you see the fifth cranial nerve, that is trigeminal nerve, cranial nerve, see this is the petrous apex. Okay, there is a petrous part of the tympanic bone, temporal bone, and this is the petrous apex. Okay, so you can see here, this is the internal auditory canal from where the tumor is arising from the vestibular part of the vestibulocochlear nerve and slowly expanding into the CP angle. And if you can see under this, here inside there will be the inner ear, and here there will be the middle ear part, and then external ear. Okay, so likewise we are seeing from above. Okay, so likewise this tumor will be enlarging and it will be compressing the fifth cranial nerve. So once it compresses the fifth cranial nerve, there will be symptoms of reduced corneal sensitivity and numbness of face. How? Why these symptoms are appearing when it compresses the fifth cranial nerve? See, once the tumor is enlarging into the CP angle, it starts compressing this fifth nerve. So let us see what this fifth nerve is exactly causing, exactly supplying. See, if you take the eyeball, and this is the cornea. Okay, so from the cornea, these ciliary nerves will arise, which carry the sensation of the cornea, and these nerves will pass through the ophthalmic branch of the trigeminal nerve and carry the sensation towards the brain. So what happens in this case, when this, okay, when this here approximately this is the area of the CP angle, you can see the trigeminal ganglion, that is the Meckel's ganglion here. So here also you can see the Meckel's ganglion sitting on the anterior face of the petrous apex. Okay, so once it starts compressing here due to the tumor enlargement, the nerves, the sensation now, these fibers cannot the sensation, the impulses through these nerve fibers cannot traverse properly, so causing the decreased corneal sensation or reduced corneal sensitivity. And also if you take all the other three branches, so all the three branches of the trigeminal will be distributing the sensory supply over the face in the same form respectively, ophthalmic, maxillary and mandibular. So once these fibers, see the ophthalmic branch and the maxillary, and also you can see the mandibular. So all these branches, these nerve fibers are getting compressed by the tumor over here, so decreasing or affecting their supply, nerve supply, the impulse transmission. So what happens? There will be a decreased sensation over the face. That is, you will be having a numbness of the face also due to this fifth cranial nerve involvement. In petrositis, which is a complication of CSOM, we have seen a triad called as Greden-Egos triad. In that, we have studied about one of the feature, that is deep-seated retroorbital pain because of the involvement of this fifth cranial nerve here in this region. And also one more feature is there in the Greden-Egos triad called as diplopia. Why? Because just below the apex of the petrous part, just below it, the Dorello canal will be passing. Through this Dorello canal, abducens nerve, which supplies the lateral rectus, will be passing. So infection of this petrous apex will also affect this fifth cranial nerve as well as the sixth cranial nerve passing in the Dorello canal near below its tip. So what happens once this nerve gets affected, lateral rectus palsy will happen, that ultimately causes your diplopia. So this is the reason of those symptoms in Greden-Egos triad. Okay. So coming to the next cranial nerve that is involved, it is facial nerve will get involved next. If you take the facial nerve from the intracranial part, it travels and it comes, see if you can see here, from the brain it arises and it starts traveling through the CP angle. Okay, this is the part, the CP angle part. Okay, the CP angle area. If you see, this is the CP angle area. So this is the CP angle part, and the nerve enters into the meatus. Okay, into the meatus. That means internal auditory meatus. So as you already know, it lies in the anterosuperior quadrant of the internal auditory meatus over here. This is the meatal part. You can see the meatal part over here. Okay, and after crossing the intrameatal part, it travels above the labyrinth. Okay, so this is the labyrinthine part. Just in the labyrinth, just above to the labyrinth, it will pass. Okay, if you can see here from above, see, this is the cochlea. I am seeing from above, superior view. So this is the cochlea lying anteriorly, and see, you can see semicircular canals lying posteriorly. So you can see the vestibular fibers passing over here, cochlear fibers passing over here, and you can see the facial nerve passing over here just above the labyrinth. Okay, so this is the labyrinthine part of the facial nerve. Okay, so once it crosses the inner ear, the immediate next outer part is the middle ear. So see, this facial nerve, just when it enters the middle ear, it turns 135 degrees. See, the angle made by it is approximately 135 degrees. It turns posteriorly and it travels horizontally, just lying above the stapes foot plate. Okay, if you see in the middle ear, see, once it enters the middle ear on the medial wall, it runs horizontally, just lying above to the stapes foot plate. And once it reaches the posterior wall, it turns down and goes vertically. So when this enters the middle ear, there is a ganglion formation that is called as geniculate ganglion. This area, approximately 135 degree turn is made here. That is your geniculate ganglion. See the geniculate ganglion. From here there is a branch given. So you can see the facial nerve running and turning over the medial wall of the middle ear, running posteriorly. Here from the geniculate ganglion there is a branch given. That branch is called as greater superficial petrosal nerve, which joins with the deep petrosal nerve later on and forms Vidian nerve. So this nerve supplies the lacrimal gland of your eye, which is responsible for the tear formation. So if this nerve cannot transmit impulses properly due to the formation, due to the compression of the, see here, in the cerebellopontine angle, the vestibular schwannoma will arise and compress the fibers over here. So through the greater superficial petrosal nerve, the lacrimation fibers are coming and they are traveling through this nerve towards the brain. But here, due to the compression, they are unable to function properly. So what happens ultimately? There, the reduced lacrimation will be there. And next, as it passes horizontally, over the tympanic part, medial wall of the middle ear. And when it passes vertically, down, it will give rise to another branch, that is your chorda tympani. Okay, as you know, the chorda tympani, see, you can also see as it passes down, it just before exiting the stylomastoid foramen, it will give rise to chorda tympani. Okay, see here the chorda tympani branch will be given, and this branch will supply the anterior 2/3 of your tongue. It runs anteriorly and supplies the anterior 2/3 of the tongue taste sensation. So this taste sensation will be lost because the fibers through the chorda tympani will be passing like this. If you take here the chorda tympani, the fibers will be passing like this, and through this nerve all these fibers will be traveling, and once they reach this region, here again the tumor is compressing. So again the chorda tympani will be unable to conduct the impulses properly. So that gets affected. And as you still come down, there is a posterior auricular nerve that supplies the posterior meatal wall, external canal wall, posterior wall will be supplied. So there will be reduced sensation of that part even, because these fibers again has to travel in this way, right? Again these fibers has to travel along, and they carry the sensation from the posterior meatal wall towards the brain, but on the way again this nerve, this tumor is compressing here. So what happens here, you will get this sign is called as Hitzelberger sign, loss of sensation or hypoesthesia over the posterior meatal wall. So these features will be there. And how would you identify that reduced lacrimation? The test done for to test for the reduced lacrimation is called as Skirmer's test. This is an MCQ, can be asked. And loss of taste can be tested by electrogustometry. This is also an MCQ. And Hitzelberger sign is also an MCQ. It means there is a decreased sensation over the posterior meatal wall due to these fibers getting affected. Okay, so remember these are the features when facial nerve gets involved. And coming to other cranial nerves, as you go down towards the jugular foramen, jugular area, these tumor will start compressing the 9, 10 cranial nerves also. And as the ninth nerve, glossopharyngeal, supplies your pharynx and vagus supplies your esophagus, there will be a difficulty in swallowing. That is, so the patient is also will be complaining of dysphagia. And your 10th cranial nerve, with the help of its recurrent laryngeal nerve, supplies the laryngeal intrinsic musculature. So affecting the 10th nerve here above will cause hoarseness of the voice even. Okay, and also you can see the brainstem and cerebellum part. So once the brainstem, through the brainstem all the spinal tracts will be running. So when those spinal tracts get affected, there will be exaggerated tendon reflexes as well. And once the cerebellum starts getting compressed, the cerebellar symptoms, as you all know, ataxic gait, inability to walk along a straight line, getting fall towards the affected side, as well as other features like intention tremors, dysdiadochokinesia, past pointing, all these will be affected. Okay, and as this starts again, still further enlargement will cause compression of the ventricles of the brain, increasing the intracranial pressure. Once the intracranial pressure increases, all those symptoms can be seen: headache, nausea, vomiting, diplopia, papilloedema, and blurring of vision. As optic nerve gets involved, blurring of vision will be there. So all these features will start. So depending on the symptomatic presentation of the patient, we can clinically assess the stage where the patient is present, or the tumor size approximately we can assess by testing for the cranial nerves. So cranial nerve function should be done in case of a patient of vestibular schwannoma. Just remember these three words: Antony A, Antony B, and Verroque bodies. These are seen in the histopathology of a tumor of vestibular schwannoma. See, Antony A means the compactly arranged cells are there, elongated spindle cells, and these compactly arranged groups are called as Verroque bodies. Okay, this is Antony A pattern. And if you see, this is a Antony B pattern. All the cells are arranged loose and less cellular. Okay, loosely arranged. So this is Antony B pattern. Just remember these three words, may be asked as an MCQ: Antony A, Antony B, and Verroque bodies. Right. So coming to other investigations, the pure tone audiometry, you can see a severe sensorineural hearing loss. So this is red color, that means it is of right side. Right side, you can see the left side quite normal, no hearing loss at all. You can see the right side curves, both air conduction and both bone conduction. There is no air-bone gap here. That means it is a sensorineural type. Okay. So right-sided unilateral SNHL will be the presenting symptom along with tinnitus initially. And coming to the other investigations, mainly in retrocochlear lesions, the speech discrimination score will be very poor. Normally it is 90 to 100%, less than 90% in cochlear, 70 to 80% it will be there in the cochlear. But if you come to retrocochlear lesions, it will be around 20 to 30% only. That means it will be very poor. So rollover phenomena will be present here. Tone decay will be more than 25 decibels. Absent stapedial reflex and abnormal bera. All these features will be seen in retrocochlear lesions. Whereas in cochlear lesions, you will be seeing recruitment phenomena and a better CC score. So all these investigations are explained well in the video on Meniere's disease. So if you want, you can go through that video also. So many MCQs can be framed from here. So simple rollover phenomena seen in acoustic neuroma, recruitment phenomena seen in Meniere's disease. CC score is high in cochlear lesions like Meniere's disease. Likewise, many MCQs can be based on this table. So go through it carefully. And coming to the other investigations, the gold standard investigation is the MRI with gadolinium contrast. See, this is the T1 image of the acoustic neuroma, and when you give the contrast, it enhances very well, takes up the contrast very well. See the T1 with contrast image. See, this is the gold standard investigation of a acoustic neuroma is MRI with gadolinium contrast. And if you see bilateral vestibular schwannomas, it is mostly seen in Western neurofibromatosis type 2, also called as von Recklinghausen's disease. Here chromosome 22 is involved. And you also have neurofibromatosis type 1 where chromosome 17 is involved. Just for your remembrance, to remember which chromosome is involved in neurofibromatosis type 1, if you count the number of letters in neurofibromatosis, it will be 17 letters. So you can remember it as a chromosome 17. And in NF type 2, NF 2 letters it is having type 2. So 2, 2. So chromosome 22. Likewise, you can remember like a mnemonic. Okay. So this is one of the most frequently asked MCQ. And coming to the surgical approaches. So if there are 3 surgical approaches. See, this part of the bone can be removed, and once I remove this part of the bone, middle cranial fossa, I will be straight around above the lying over the petrous apex part, and I can remove the tumor over there. Okay, and the other route is translabyrinthine. But if I go through translabyrinthine means through the labyrinth, through the inner ear. So I can go through the inner ear, but what happens here? Hearing will also be lost. Once I damage the labyrinth, there the hearing will also get lost. So if there is no serviceable hearing, that means if the hearing is very poor that it cannot be revived back, so you can go through this translabyrinthine approach. And another approach is your retrosigmoid or suboccipital. See, this is the sigmoid sinus running over here, and this is retrosigmoid, back to the posterior to the sigmoid, retrosigmoid approach. You can go and towards the petrous apex, and there in the CP angle you can remove the tumor after removing this bone flap craniotomy. Okay. So 3 approaches are there for surgery. And coming to the other methods where surgery is not feasible, like a 60-year-old with many comorbidities who is not fit for anesthesia, in those cases you can go for radiotherapy. So not the conventional method is not much useful here. It's the stereotactic radiosurgery. Approximately 12 gray of radiation can be given. See, the patient will wear a frame and sit, and on the computer software the tumor will be localized with the help of MRI, and all the markings will be made where how much amount of radiation and which place it has to be given. That configuration will be marked, and then once you see on the system, see from all the directions the radiation will be focused on the single tumor area only, so that the surrounding areas are not much exposed. This is the advantage with stereotactic radiosurgery, which we will miss in conventional. In conventional, the surrounding tissue will get much damaged, but in stereotactic that is not the case. Okay, so there are different methods: X knife, gamma knife, cyber knife. So many cyber knife is the recent robotic arm. With the help of that you can give radiation. And X knife and gamma knife, where gamma knife uses cobalt 60. Most commonly used is the gamma knife. Cobalt 60 is the source here. Okay, so that's it. With this we end the acoustic neuroma.